Hello, friends. So today I'll be talking on this topic, which was given to me as a debate in St. John's on 10th September. So this debate was against another colleague of mine. So I had to talk in favor of saying that P-SILI, which is patient self-induced lung injury in ARDS, is a myth. So the way I would go about is the only way we can understand SILI is to understand the physiology. So we need to understand various pressure that maintains the milieu in the lung. So when you look at this, so the airway pressure, what we say is is a reflection of alveolar pressure. So we need to have that clarity in mind. And the pleural pressure, which is so important in determining the transpulmonary pressure, which so much we talk about plateau pressure, transpulmonary pressure, because transpulmonary pressure is what determines the injury to the lungs. So the way to measure, obviously we cannot measure pleural pressure because we have to keep a probe in the pleura. So the surrogate of that is esophageal pressure. As you see, the esophageal pressure is a reflection of pleural pressure. So based on these pressures, there are a lot of derived pressures. So one of the derived pressure is pressure of the respiratory system, PRS, as you see the red arrow here. So P respiratory as the arrows, just remember these arrows. So respiratory system is airway pressure, which is the alveolar pressure minus atmospheric pressure. So that is pressure of the respiratory system. And PCW is the chest wall pressure. So chest wall pressure is pleural pressure, which is esophageal pressure minus atmospheric pressure. But these two pressures may not be of too much relevance to P-SILI. What is relevant is transpulmonary pressure. So the transpulmonary pressure is your airway pressure, which is alveolar pressure minus pleural pressure, which is esophageal pressure. So whatever I'll be talking will be keeping in mind what happens to transpulmonary pressure in ventilated patients or maybe in spontaneously breathing patients in inspiration and expiration. So I just want to draw your attention on this particular paper, which created a lot of excitement during COVID, which came in intensive care medicine by none other than Gattinoni et al., where they hypothesized why I say PCL is a myth is even in the thick of COVID, they came out with this hypothesis that there are two types of ARDS, L type and D-type ARDS. And I'm sure every listener here would understand that when we spoke about L-type, we said it is low elastance and high compliance. There's nothing in ARDS like high compliance. We knew that, but this hypothesis came out. Then they said this L-type, which has a high compliance, we need to use higher tidal volume. So this is despite our clear understanding that in ARDS we cannot use high tidal volume. There was a proposition and a hypothesis stating that we should use a higher tidal volume of 8 to 9 in L-type ARDS. All this has been debunked. So P-SILI also, I would argue that it will be debunked. There's nothing like P-SILI because L-type ARDS is no longer existent. And then they said there's a H-type, which says high elastance and low compliance. For me, all ARDS is low compliance. And here, in the thick of ARDS, they confused all the doctors treating with ARDS, saying there's H-type, L-type. And H-type, they said, we need to use lower tidal volume. And then they even went on to look at the postmortem lungs, and they found some difference in certain areas where the weight of the lungs were lower, and in some of them the weight of the lungs were higher, and that may be due to various reasons. And they attributed it to L-type and H-type. And they said the L-type has low recruitability and H-type has high recruitability. And even went on to show that L-type there is a lack of hypoxic vasoconstriction, there is impaired diffusion, there is reduced ventilation perfusion mismatch, and there is increased negative. Why we are talking about COVID now? It is all done and dusted. Is during this L type and H type, they hypothesized that the L type of ARDS is where the SILI exists. So this is where I want to debunk the whole philosophy that SILI does not exist because there's nothing like L type ARDS, where there is high elastance and low elastance and high compliance is a misnomer, and P-SILI does not exist because we know we have debunked all this. There's no L-type ARDS. And they went on to say that, and they showed some pictures saying the L-type ARDS look something like this. And the H-type ARDS, they said there'll be ventilation perfusion mismatch and there'll be more consolidated lungs. And in this paper, they went on to show in the further subsequently that L-type, which is low elastance, high compliance, where SILI occurs, P-SILI occurs, they said one has to use your HFNO or NIV, which we agree. Okay, any type of ARDS, yes, we need to use certain PEEP. PEEP is always very friendly. We need to use HFNO or we need to use NIV. And they said that L type, which has a high compliance, have increased work of breathing. So to mitigate that, we need to use this. Yes, we agree with that. And this was shown as a methodology to reduce the P-SILI, and they proposed that high PEEP is needed. Yes, we agree with that. And they even went on to say that the esophageal pressure or the delta esophageal pressure or the transpulmonary pressure, which they were referring to, should be kept sort of a low. And if it is more than 15, there is increased risk of PCL. Even that we tend to agree, because we do not want to have too much of negative pleural pressure, because what they are telling is the esophageal pressure is reflective of your pleural pressure. So if the negative pleural pressure is more, then there is an increased risk of P-SILI, is what they said. That we agree, because wherever there is a pathology, there is more negative pleural pressure and it causes more damage. That we agree, but that does not mean that P-SILI is something which exists. Okay. So that was the sort of insights that we could draw. And they even went on to say that, these are the patients we should be prone, blah, blah, blah. So this was some of the insights that we derived from that paper. So what have we understood until now? So in patients who are on mechanical ventilator, when they are made to breathe spontaneously, and where there is increase in the respiratory rate, where there is tachypnea. So if we are making ARDS to breathe spontaneously and patients are tachypneic, and most often it is due to inadequate PEEP, and it may be due to increase in the tidal volume due to increase in the pressure support during inspiration. So these are the two things which are something which causes more harm. And in patients with ARDS for tachypneic, because of inadequate PEEP and increased tidal volume delivery to the normal lungs due to increased pressure support, so we call this entity as it causes damage in the areas of the lungs which are well aerated, and we have understood this sort of a situation as ventilator-induced lung injury. So what happens in spontaneously breathing? In spontaneously breathing, when there is tachypnea and when there is increased work of breathing, so what we see is there is increased generation of negative intrathoracic pressure, which means your negative pleural pressure tends to increase. There is increase in the tidal volume. And this we call it as, and this leads to increased lung permeability, and this we call it as P-SILI. So for me, the P-SILI and VILI is what we call in ventilated patients is very similar to P-SILI in spontaneously breathing. Because in ventilated patients, you don't give good PEEP and you give increased pressure support which is leading to increased tidal volume. So this leads to what is called as VILI. And this VILI is very similar to P-SILI in spontaneously breathing, where there's increased generation of negative pleural pressure, which leads to increased lung permeability and P-SILI. So this is what we can decipher from the available sort of a literature, that this is what happens. So now we need to really understand in patients who are ventilated or who are having ARDS, what really happens. So there are two components we need to understand, because there are two different sort of a physiological phenomena that happens, one during expiration, and there is a different phenomena that happens during inspiration. So during expiration, obviously this is in a ventilated patient, so you have this ARDS lung where there is alveoli which is collapsed. So during expiration, it's the PEEP which is beneficial. So you're giving a PEEP of 5. So the negative, uh, the pleural pressure is always more at the site of pathology where there is collapsed alveoli. So the transpulmonary pressure is your airway pressure, which is PEEP of 5 minus pleural pressure, which becomes 6. Transpulmonary pressure is 6. And here the transpulmonary pressure is airway pressure, which is 5, and minus pleural pressure, which is 2, minus minus, which is 7. So these pressures are not good enough for this lung during expiration, but during inspiration, there is a different pressure that adds. So we add pressure support. So when a pressure support is added, what happens? This gets added on. So your transpulmonary pressure in the normal aerated lung is more, 15. And in the lung which is collapsed or where there is ARDS, so this PEEP and this pressure support leads to transpulmonary pressure of 18. Because the PEEP is only 5, it is not good enough to have opened this alveoli, but your transpulmonary pressure has increased because you have added in your inspiratory pressure. So what you have essentially done is you have not really helped the diseased lung, but you have over distended a normal alveoli. And this we call it as volute trauma. So what we are really understanding is there are two separate processes that happens during expiration, and more harm is caused during inspiration, where your inspiratory pressure is added, which leads to over distension of normal alveoli, but has failed to open up the diseased alveoli. So we do not want this situation. So then we tend to circumvent this by increasing the PEEP. So we increase the PEEP to 10. So I'll quickly run through these slides. So transpulmonary pressure becomes 11. So during expiration, it's not a problem. This is good enough. But during inspiration, you add pressure support. So with 10 of PEEP, you have done some good in opening this alveoli. Transpulmonary pressure has become 20, but here the opening is not complete. Transpulmonary is good enough, but it is still not fully opened. So there is opening and closing of this partially distended alveoli, which leads to atelectotrauma. Even this situation is not good enough for us. So then we further increase the PEEP. So that's why the whole focus in ARDS is on PEEP optimization. What we are essentially telling is how useful PEEP is to mitigate volute trauma, how effective PEEP is to mitigate atelectotrauma. And now you have increased the PEEP to 14, which is good during expiration, and transpulmonary pressures are 18. And you have increased PEEP here to 14, which is good, which has opened. But you have still added pressure support. So transpulmonary pressure goes up to 26 and it goes up to 30 on this diseased alveoli, which is too high, and this possibly leads to barotrauma. So recruitment with possible overdistension. So the only solution we have is how do we reduce this 30? Obviously, PEEP has been good because you see during expiration it has opened up alveoli nicely, but during inspiration the transpulmonary pressure has further increased because the only way we can optimize this is to reduce your inspiratory pressure or pressure support. So what we do next is, so we want this, but we do not want that. So what we do now is we reduce the inspiratory pressure. So here you see pressure support is reduced to 3. And this is the ideal situation we want, where you have transpulmonary pressure of 19 and 22, which is compatible with lung protection. So this is the whole physiological sort of a rationale as to why PEEP is so important to protect the lung. So this is what we have clearly understood as to what happens during inspiration. So we have to be PEEP friendly, and PEEP is the only way that we can avoid what we call as VILI, which exists in sort of normal breathing patients. So this is what we have understood. So now let us get back to the VILI. So if it is spontaneously breathing, patient is breathing at a lower PEEP, and as I said, the negative pleural pressure is always more at the site where the lungs are affected. So here the lung is consolidated and ARDS, negative pleural pressure is more. And in the normal lungs, as you see, the negative pleural pressure is less. So where the negative pleural pressure is more, your transpulmonary pressure is more. And then there is increased contraction of the diaphragm also that happens when there is increase in the negative pleural pressure and there is lack of PEEP. And this also leads to maldistribution of the lungs. And then all this leads to the over distension of the normal alveoli. There is increased permeability in the lung. There is increase even in the perfusion of the alveoli. And this leads to asynchrony. And this asynchrony, there are two types, which can be double triggering in spontaneously breathing. In overtly sedated, there can be something called reverse triggering. So all this leads to more perpetuation of ARDS that we see with a lower PEEP. So what happens when we give optimal PEEP? When we give, and there is an interesting entity called pendelluft mechanism, where there is redistribution of air from the normal aerated lungs. Yeah, all these aerated lungs, the aeration gets redistributed to the pathological area, and then there is a over distension of the alveoli. And this has been shown in multiple studies. So there is redistribution of the lung from the non-dependent lungs to dependent. So if you see this figure, just focus on this figure. The non-dependent lung without proper PEEP, there is 75%, which is aerated, and dependent is 25%. So in pendulum, so there is in a spontaneously breathing. Once the patient starts breathing spontaneously, there is redistribution. If you see, non-dependent has become 49% and dependent has become 51%. So spontaneously, when breathing patients, there is redistribution from the non-dependent to the dependent, but in a controlled ventilation, this redistribution does not happen. So this is what we call as pendulum, which tends to happen in spontaneously breathing, and it can get perpetuated in severe ARDS patients. So at higher peak, what happens? At higher peak, what you have seen, there is good redistribution of the gases. Your negative pleural pressure, which was 20, now as you see, since you have recruited alveoli, negative pleural pressure is come down to 13, and that leads to reduced transpulmonary pressure, and that leads to reduced contraction of the diaphragm. There is more even distribution of air, and then that leads to better recruitment of alveoli and better homogeneous distribution of oxygen. And this pendelluft mechanism also tends to be circumvented to some extent, and there is a better gas exchange with higher PEEP. So the whole philosophy is in ARDS, in spontaneously breathing. If you have optimized PEEP, then there's nothing like an entity called SILI, because SILI is only a reflection of perpetuating of ARDS or progressive worsening of ARDS because we have not optimized the lung function with our PEEP. That's what we have clearly understand. So P-SILI is only another jargon name that is given to worsening ARDS. So this is what I wish to say. And it has been shown clearly in a lot of animal studies and in physiological models. So this is again a graph to show this is the airway pressure where you have given a little bit of a PEEP. So if you see after you have given the PEEP here, so here you have given the PEEP here, and after you give the PEEP here, this is the pleural pressure. The more negative pleural pressure has come down. See, this is the more negative pleural pressure. It has come down, and this has shown to reduce the transpulmonary pressure here. So this is a physiological model where they have shown by increasing the PEEP, your negative pleural pressure is circumvented, and your transpulmonary pressure comes down. More even distribution of lung happens, and all this P-SILI and the perpetuation of ARDS does not happen. So my conclusions in this debate is P-SILI is a theoretical scientific plausibility. So it is only a plausibility where you have not given PEEP. So this does not exist in an ICU situation where all our intensivists are trained and they know how important is PEEP. Once you have understood this, this entity does not exist in in our ICU, and there is no clinical or practical relevance of this P-SILI in modern ICU because all intensivists are PEEP friendly. They put patients on NIV, they use HFNO, which I showed in COVID, where you say L type, low elastance, high compliance, you need to give. Yes, we don't allow patients to be tachypneic. We put them on HFNO, we put them on NIV. So there is no clinical or practical relevance of P-SILI. It's just another name for mismanaged ARDS, where you have a patient with ARDS, you sit quietly and watch them on a normal mask oxygen, and he progressively worsens because you're not given any PEEP. So there is a perpetuating worsening of the ARDS or injury that happens because you're not recruiting the alveoli, and all those physiological conundrum happens and patient worsens. That we call it as a SILI. So, and why I say it's a mismanaged, just another name for mismanaged ARDS is because the situation is a patient comes to ICU with ARDS who is very tachypneic, who has bilateral infiltrate. Obviously, you won't sit there and watch him worsen. You would put him on NIV, you would put him on HFNO. So we would have mitigated that progressive worsening, which we call it as a PCILI. So these are my conclusions, and obviously my opponent would have argued as to why PCILI is something that is pertinent. So my rebuttal is, so this is a normal patient who goes for a run, and my opponent runs like crazy. So after you run, you keep panting. So do you develop PCILI? So would this patient develop P-SILI? No. The answer is no. You become tachypneic, you don't develop P-SILI. Okay, even we see so many pneumonias in lung in our practice. So mild to moderate pneumonia, they may be little tachypneic. Does P-SILI occurs? The answer is no. So why is it that we are telling P-SILI is an entity only in ARDS? Why? Because in ARDS, we are meant to optimize PEEP, and that has been our teaching. So P-SILI is known to occur only in spontaneously breathing ARDS because of that pendelluft where there is redistribution, over distension of alveoli in the normal areas, and more leakage and more sort of exudation that happens, blah, blah, blah. So in spontaneous breathing, if it is a ventilated patient, we call it as a VILI. But if it is spontaneously breathing, we do not allow our patients in ICU on a non-rebreather mask with ARDS, period. So there's no SILI in ARDS. So when someone we find on an NRBM with ARDS, we connect them to NIV or HFNO, we'll give more PEEP, and this would mitigate this perpetuating worsening of injury, which we call by this name P-SILI. So my argument is P-SILI for an evidence-based medicine intensivist, because I believe all my listeners here are intensivists who are trained, who are so good in putting patients on ARDS on an NIV, HFNO, or intubate in severe ARDS. It's only a myth. PCLE is a myth, and it's a hypothetical jargon. So you have to induce this sort of a situation where you just fold your hands and watch the patients being very tachypneic, don't do anything, put them on NRBM. This situation is no longer prevailing in any of our modern ICUs. So it is just a myth and hypothetical jargon, like how it all erupted during COVID, saying we have LARDS or HARDS, L type, H type. All that has been debunked after COVID when no one believes that. And this PILI also originated from that L type. And we know L type does not exist. If L type does not exist, then P-SILI also does not exist. So that is my submission that P-SILI is a hypothetical jargon. So on these notes, I'm sure many of you know I'm a medical philatelist. So Laplace is one of a fantastic sort of a scientist or a discoverer of oxygen. So this stamp was released in 1955 by France. So the way we recognize Laplace is in 1779, he called dephlogisticated air, which was identified by Lavoisier and coined the name oxygen as Greek word. Why I'm showing him? Because he made a very important quote, which is very applicable to this debate. He said, the weight of evidence for an extraordinary claim which my opponent is making, that PSILI exists, must be proportioned to its strangeness. So I would say it's very strange if someone says PSILI exists in ICU. It's a very strange thing because there is no evidence that substantiates that. And he also says what we know is not much, what we do not know is immense. And this was told by this great man Laplace. So I end my debate there. So I request all my listeners to submit their valuable work to this Journal of Acute Care, which is a quarterly journal. So it comes every 3 months. So request each one of you to submit and visit my website, www.drpradipangappa.com to react to this lecture. So I end with this another quote. Perhaps the greatest myth being pervaded is that myths are just myths. So thank you, one and all.